Welcome, everyone, to a special edition of St. Michael's Foundation's Powerhouse Speaker Series in support of International Women's Day. I'm Dr. Pat Ocampo, the Executive Director of the Li Kai-shing Knowledge Institute at St. Michael's Hospital. We'd like to acknowledge this land, the people, and all other beings, animate and inanimate today, as well as the ancestors. This area has been a place of Indigenous communities coming together for well over 15,000 years. This land has been the territory of the Huron-Wendat, the Petun Nations, the Seneca, and most recently, the Mississaugas of the Credit First Nation. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. Today, the meeting place of Toronto is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work in the community. We are also mindful of broken covenants and the need to strive to make right with all our relations, sharing stories and telling the truth of this place, Miigwech. Today is no ordinary powerhouse. Today we are talking about a problem that affects pretty much every woman, no matter their backgrounds, no matter their life circumstances, no matter their stage of life. The unfortunate reality is that women face barriers when it comes to their patient care experience, simply because they are women. So today we've brought together women leaders from across St. Michael's Hospital and Providence Healthcare for a conversation about the challenges women face throughout their healthcare journey and our plans to address what's broken. Here are just a few eye-opening stats. Women are diagnosed later than men in 700 diseases. Even though women experience more chronic pain than men, they receive less pain medication and less effective pain medication. Women are prescribed more antidepressants and they receive more referrals to mental health services. In other words, there's the perception that it's just your imagination. So what's going on? Well, one issue is that women only started being included in clinical research as recently as the 1980s. That meant that treatments, including medication and its dosages, were developed specifically for men. In some cases, it's proven fatal. Another issue, women's health research is chronically underfunded. Canada funds grants to support researchers' salaries, which provide scientists with critical resources, but only 1% of those grants go to women scientists. Grants that focus on women's health make up only 8% of national funding. This despite the fact that women make up over half of the population. These aren't just Canadian issues. Statistics like these are repeated across high-income countries globally. This is how some women describe their care experience. This is Aaliyah. Quote, I think a lot of women would probably say they're tired of being treated in pieces, like we fix your uterus, or we fix your brain, or we fix your heart. But women are much more holistic. Our expectation is that we'll be treated more as a whole. And from Nika, who notes that women often have added responsibilities for caregiving. Quote, women shouldn't have to ignore their healthcare needs because there's no one to care for their children for an hour. In one study, older women report not feeling listened to, that their complaints are not taken seriously. A serious condition that should have been caught early enough to be treated easily isn't. Eleanor said she felt judged for, quote, having a baby before what society feels is proper. Another woman with HIV said, quote, I feel like I've committed a crime. We see these issues day in and day out in our work at St. Michael's and Providence. Have a look.
There are a lot of issues today when it comes to women navigating the healthcare system, and I kind of put them in two big broad categories. The first is sort of design and access. We sort of have this one-size-fits-all system where we try to make everybody fit into sort of one way of doing things, and we know that women are different, our bodies are different, our lifestyles are different, our responsibilities are different, and so sometimes navigating the responsibilities of being a woman and accessing the healthcare system are in direct conflict with each other.
I think the pandemic has also exposed some gender inequalities that have long been present in our society. So for example, women in Canada actually provide the majority of the unpaid caregiving work. And this has really been exacerbated during the pandemic because schools have been closed. Programs for seniors and adults with disabilities have all been closed because of COVID. And this has created an increasing strain on our women.
I see some significant issues facing women in accessing mental health care. And accessing healthcare isn't just about getting in to see somebody. It's also about the kind of treatment that you get, the follow-up care that you receive, or the stigma that you might experience from other healthcare professionals.
There continues to be gender bias in the way we identify medical conditions and we treat them. And so that is something that we continue to need to tackle both on the front lines as individuals, but also as researchers and healthcare systems.
Not all women are having the same experience. So women who are more marginalized, those who are living in poverty, those who are racialized or indigenous, who have different abilities, who can't speak English, they're having a different care experience. Unfortunately, as a result of things like racism or not being able to access care in the language that they're most comfortable with, as an example.
The entire body of health research that we base all of our clinical practice on is largely data that we gathered from men. And I think until more women are integrated into the research process, doing research, participating in research, and having research done about us, I think that we're still going to have therapies that are targeted for people other than our bodies.
I think there's still a lot that needs to be done. We know that there's gender bias in how we still diagnose and treat women for various medical conditions. However, we're very fortunate at St. Michael's Hospital to be part of a large research community as well. And as a result, we have the opportunity to work with some of our researchers to really close that gap.
So another way I think we can improve the care experience for women in healthcare is by looking after our healthcare workforce, because 80% of our healthcare workers are women. And women need psychological support right now, dealing with the trauma of the COVID pandemic. They need access to full-time work opportunities, sick time, benefits, and opportunities for professional development and career advancement. And we need actually more women in leadership roles, because even though we make up 80% of the healthcare workforce, we are underrepresented at leadership tables. And this is especially true for Indigenous women, Black women, and women of color. And diversity of women at the leadership tables will help influence the policies and processes and procedures in place in our healthcare system.
So there's many factors I think that we need to think about when we're thinking about women who come from different backgrounds with different needs. And I think we should really be prioritizing those different needs as we think through the care journey.
What I'm really excited about is the opportunity to involve women across all aspects of redesigning healthcare. I think the representation is extremely important. Women need to be involved in leadership. They need to be involved in research. They need to be involved on the clinical front line. And female patients need to be included in our design and delivery of a future healthcare system. And the fact that we're willing to do that here is so exciting.
The good news is that I see a lot of opportunity for change. And I think as clinicians, our role is to help patients to feel like their experience is being validated first and foremost. And secondly, to help them to become advocates for their own healthcare. And that can be also around learning about their symptoms or their diagnosis so that they can ask the questions they deserve the answers to make informed decisions about their treatment plan.
What does human care mean to me? It means care that is respectful, kind, and compassionate. That meets people where they're at. And that's not just person-centered, but community-centered. That it takes into account the background, the experiences that shape the health that someone has.
that patients' needs are met, not just in terms of their physical or medical needs, but their spiritual, emotional, and human needs, really. It means that we are developing connections with our patients and providing emotionally focused care.
What does human care mean to me? It means collaborating with patients with regard to their treatment planning. It means educating them about complex topics about their healthcare. And it also means encouraging them to be advocates for their own healthcare.
It means that the people on the front lines taking care of them love their job and love being part of delivering healthcare to the people that they are meeting each day.
It means a place where women can come and access healthcare and feel like the system they're accessing was designed for them.
We've gotten rid of disparities in outcomes. No longer does your background affect how long you live. Now the care you get can help to close that gap.
So, as you've heard, there's too much distance between the patient experience women deserve and the patient experience women endure. But as you also heard, we're working to address the issues and develop the policies and practices to reinvent the care experience for women. This is what Human Care, a global movement being led by St. Michael's Foundation, is all about. It's about making sure that women and all patients get the care experience they deserve, no matter who they are or where they come from. And who better to improve the patient experience for women than women? So let me introduce our incredible Powerhouse panelists. And I can assure you, because I work with these women, the word powerhouse defines them. We've got Dr. Carolyn Snyder, Chief of Emergency Medicine, Dr. Ashley Verdun, Vice President of Medical Affairs and Chief of Providence Healthcare, Dr. Seema Marwaha, General Internal Medicine Physician, Dr. Tara Kiran, Family Physician and Scientist, and Dr. Sakina Rizvi, Scientist and Mental Health Advocate. So I'm going to dive right in with my first question to Dr. Kiran. You pointed out that women play many roles in society. They're often balancing professional lives with their home lives, along with competing demands. They're also navigating the healthcare system on behalf of others, like their parents or children. So what are some of the factors that could impact a woman's health and her healthcare experience?
Thanks, Pat. I'd like to start by thinking about accessibility, which I think is one of the most basic factors. So to start off, they have to have access to care. Every woman should have a family doctor, but they should also be able to see that doctor in a timely way. And ideally, the type of interaction they have meets their needs. So whether that's a phone call, a video visit, or an in-person visit, it should meet their needs and their preferences. It also should be accessible in terms of accounting for different types of abilities. So, some women are hearing impaired or vision impaired. They may have physical limitations. So we need to account for that, whether that, be how we talk to someone on the phone or whether we talk to someone on the phone and how we accommodate them when they come in to see us in person. I think the second factor is one that, everyone relates to, of course, is having compassionate, respectful, kind care. And although this is an attribute of care for everyone, I think, what we heard already reminds us that there's a history of paternalism in medicine, and that influences the diagnoses we make, the treatment plan, how much we know or value about women's conditions, and the power dynamic within the actual interaction. And so that's why that respectful, kind care is even more crucial when it comes to women's health. And then lastly, I think we need to really consider the broader context of the lives that women live. So that means the social determinants of health, like income, race, housing, education, employment, as well as the structural determinants, racism, colonialism, and in the case of women, sexism and transphobia. These are structural determinants that really influence how healthy someone is and whether they get to meet their life's potential.
Thanks so much. I'd like to turn to Dr. Snyder now. What kind of gender biases exist when it comes to diagnosing and treating women? And why do you think these biases are so entrenched?
Well, as you mentioned, we know that biases exist, and you outlined a few of these in your introduction. I think these exist because so often previous research was done on only on men, and as a result, that formed a lot of our knowledge in how we practice medicine, how we diagnose, and how we treat. And I personally am really looking forward to ongoing work to dismantle them using all sorts of new tools. So I'm looking forward to our new electronic health record for many, many reasons as a practitioner, but also as a researcher and as a leader, because it will allow us to really look into our practices based on gender and based on age and based on race. And we'll be able to better understand how we may be treating people differently, the time to pain medication, the amount of medication, our referral patterns, and really see our biases at play in the care we give and ensure we understand that we must make change and allow us to see the change when we do the hard work that we need to do to improve care. Um, for me, gender bias wasn't really discussed in medical school. I suspect it is now. I'm quite sure it is now. But really, what's important is that it takes practice to learn how to identify one's own bias and to make changes. Just today in our monthly meeting for emergency physicians at St. Michael's Hospital, we started an EDI moment, and that was initiated by one of our EDI co-leads in our group. And it's an opportunity for us to bring forward a patient experience that we were a part of, or another experience where bias may have occurred, where we'd actually taken the moment to reflect and seen that bias and how it affected us, how it likely affected the patient, or maybe a learner in the room, and starting to work together to practice this important reflective exercise, because it's really in doing that we'll be able to tackle a lot of gender bias and other biases that are just so inherent in what we do. And finally, and I think this is really important, is that we need to continue to fund research and innovation into understanding how we care for patients and women patients in particular. An example I like to speak of, and it's great that you're leading this discussion, is intimate partner violence. It's so prevalent across society, and in the emergency department, we see it far too commonly. We're fortunate at St. Michael's Hospital and Providence to be part of an institute that has is an academic hospital. It allows us to draw upon the knowledge that's being creative and the innovative work like yours, Pat, on caring for those who are experiencing intimate violence and other disadvantage. Maybe you could tell a bit more about your work.
Thanks, Carolyn. Thanks for mentioning both the biases and strategies to thinking about dismantling it. Carolyn, my research focuses on sectors outside of the healthcare system, like housing, the employment sector, or social services. And we see the very same biases there. Take any policy or program, and you can pretty much guarantee that women's unique needs have been ignored when those policies or programs were designed. Something as simple as benefit levels for social services are based on the very basic needs of shelter or food for individuals. And while those benefit levels are too low for everyone who's receiving them, if we were considering women's unique needs, the benefit level would consider the fact that women have higher housing costs than men, as the majority of single parents are women, requiring larger apartments than men, and women needing their housing to be located in safe neighborhoods with good schools. Housing like that costs money. Transportation costs are higher for women as they take more trips related to their families than men do. And we can go on and on about how women's needs are unique. Because of gender bias, women's unique needs are not acknowledged when we're designing programs like social services or even unemployment benefits. And there are some exceptions, of course, to organizations providing women-centered services, but they are rare. In my research, I work with these different sectors to try and get them to understand how women are harmed when their unique needs are ignored. And we work to bring women's perspectives and experiences and voices to the table to design women-centered programs as a way to eliminate these biases. But let's get back to a discussion of healthcare, as I want to hear now from Dr. Rizvi. So as a scientist and as a woman, how does it make you feel knowing so few resources are allocated to women's issues?
It's really disheartening, and it became really apparent to me, especially during the pandemic while doing suicide intervention research in terms of the reduced access to programs that are unique to women's needs. And I can even speak to that personally from going through health issues as a woman and really felt I wasn't being listened to. And for what ended up being a mild cancer, was told even as a mental health professional that maybe I was just depressed. So I also see how beyond resource allocation, women's healthcare needs are often minimized. So I think it's really time to be bold in what we do next. And there's so many women at St. Michael's that are working to reverse this, including my incredible co-panelists here, who are implementing ways to optimize care, building specialized programming. And I think it's also promising that even when it comes to major research grants, that there's more of a focus on ensuring that research questions and analyses consider the unique aspects of sex and gender. So I'm really optimistic. I do see it changing. And in the meantime, I think as clinicians, we need to work harder to ensure that women feel cared for when they're seeking help, which is really what the Human Care Campaign at St. Michael's is really trying to push.
Thank you. Let's see, we haven't heard from Dr. Verdun yet. What role has the COVID-19 pandemic played in exacerbating some of these issues, particularly for elderly women?
Yes, thanks, Dr. Ocampo. The last 2 years have been particularly challenging for older women living in the community, older women living in long-term care and retirement home settings. Home care in particular, that has been an under-resourced part of our healthcare system even prior to the pandemic, and has certainly been exacerbated throughout the COVID-19 pandemic. And this has really put a lot of our older women at risk who are living in the community. Many older women live alone. They continue to play a caregiving role. They may be supporting a partner who has a chronic health issue, perhaps a partner living with dementia, and they rely on home care to meet their basic activities of daily living. So they require home care to support, for example, bathing, for example, eating, drinking, transferring. And unfortunately, the reduced access to home care has really led to a health decline for many women living in the community. It's also led to a higher burden of caregiving, I'd say, in our older women, and particularly those that, like I mentioned, are living with a partner who has dementia. A lot of the programming for seniors has been closed throughout the pandemic. And this has really created an increased caregiving burden on older women. And older women aren't only providing caregiving support to, for example, partners, but also to grandchildren. And we don't often talk about that, but I think they've played a big role in filling the gap when there's been closures of daycares and closures of schools. And this has perhaps also limited their access to healthcare for themselves. And at Providence, we have a really lovely long-term care home. And I'm sure everyone's heard about the impact of COVID-19 on those living in long-term care, but it has had a devastating impact on women in long-term care and the workforce of long-term care. And I don't know if everyone is aware, but 90% of our healthcare workers in long-term care are women, and many are actually older women too. And this particular group of healthcare workers, I think the pandemic has exposed the challenges they've been experiencing actually for decades. They've been undervalued, underpaid. They haven't been receiving sick time or benefits, and many have been relying on multiple jobs to meet their financial needs. And certainly, this impacts the quality of care that's provided in long-term care, and it's something that we as a society really need to work to change.
Thanks so much for highlighting both the needs of patients and the needs of older healthcare providers who are women. Dr. Mawaha, I'd like to turn to you now. You said the thing that excites you most about being a doctor at St. Michael's is working alongside people who have the courage and willingness to design and do things differently for different groups of people. What does it take to break that one size fits all mold and way of thinking?
Thank you so much for this question. I think a lot of my co-panelists exhibit what it takes to break this mold. So I'm excited to share this Zoom stage with them. But it takes a few things. It takes courage to break historical molds and to do things differently, especially when you're taking on things like entrenched paternalism in the system. You have to be open to disruption and to bottom-up ideas for change. And big healthcare organizations are often not open in this way. It takes compassion to understand experiences and backgrounds that are distinct from our own so that we can make it so that patients not only get care, but also feel cared for. And then it takes insight, insight into the structural and historical inequities that affect healthcare outcomes of patients. Entrenched paternalism, colonialism, racism, they exist. And it makes it so that people sometimes need care delivered to them differently to be able to get care. So for example, arranging tests for a single mother around school hours so that she doesn't need to get childcare, that's not special treatment, that's equitable treatment. And I think it's really important that we see it that way. And then lastly, I think it cannot be understated, it takes space, physical and cognitive space to make these changes. We can't ask people to do things differently without giving them the time, the resources, the funding, the research to succeed in this mission.
Thank you so much. What I'd like to do is maybe switch gears just a little bit. I still have questions for you, but I'll let you decide who's going to answer these questions. So my first question is, what's one thing that could really make a difference when it comes to improving women's healthcare experiences? Anyone can jump in.
I think that, coming from what Dr. Snyder was speaking about gender bias, when I was doing my clinical training in psychotherapy, there was a concept that was so heavily entrenched in every aspect of what we did. And it was called safe and effective use of self. And it was about, can you learn and understand how your subjective life experiences and how your patterns of interacting with people can be impacting how you are interacting with your clients or your patients. So I would have to write essays on what cultural experiences have you had that might prevent you from listening to someone. And if you weren't bringing your reflection game, you weren't going to pass that assignment. So it was really, really important. And so when we think about short-term versus long-term strategies, this is something that is, a low-hanging fruit in a way where it's a low-cost way to start to develop the reflective tools, because it is a skill set to try to address these gender biases so that we can start to tear down some of these paternalistic, expert patient interactions where we can be more collaborative. And then a clinician will just naturally be more curious and attentive to their patients.
Anyone else?
Yep, I'm happy to speak on this as well. Thanks, Pat. Yeah, I completely agree with Dr. Risby. And I also just want to highlight again, from my perspective and working with older women, I think the one thing that we can do to improve their healthcare experience is to really listen to the way they'd like to age. The way, where and when and how that happens should be really up to them. And we should be able to support them in that wish and in terms of their quality of life, whether it's living at home or living in a retirement home or living in long-term care. And I think the way to do that, again, is to support our healthcare workforce who are working in home care and who are working in long-term care. And I think that's the one thing we can really do to improve the care experience. And certainly I think if most women that I speak to would prefer to age at home, and yet many don't have the resources they need to do so. And those that live in long-term care, what we know is that the value of emotional connections in long-term care is what really provides quality of life and care to them. And the way that we can support those emotional connections is by improving the staffing levels of long-term care and giving our staff the tools they need. And actually, just to mention Dr. Risby again, she's actually leading a research project right now that's helping our staff improve their trauma resiliency. And I think we don't hear and speak about this enough, but the trauma that our healthcare workers have experienced throughout the pandemic really need support right now to manage that. And that way, if they're feeling well and feeling happy in their work, they're going to provide the best quality of care for the women they're looking after.
Thanks so much. The COVID pandemic has really affected so many of our healthcare workers. Anyone else for this question?
I was hoping to jump in if there's time.
Absolutely.
I think from a care delivery perspective, there's sort of three things that seem like stating the obvious, but I think they need to be stated. And it's that women are not just men with uteruses. We are distinctly different. We require different treatment pathways, different research, different care delivery. We're also not a homogenous group. We're extremely diverse, and that needs to be recognized. And we're a huge part of the population, 50%. And so we need dedicated research, different treatment pathways, different needs in general. And, it's sad to me sometimes, it's 2022 and we still have to acknowledge some of these things. And then I really do think that representation matters. And so having women representation in all medical specialties, even the ones that are traditionally underrepresented and male dominated, like surgery, interventional radiology, cardiology in some places, is also key in providing care, in training the next generation, which should include females, and in defining research and care priorities. I mean, representation is not the magic answer, but I definitely think it's a start to ensuring that the care needs of women can be met now and in the future.
Thanks so much. Okay, I've got another question for you. And again, feel free to jump in. What are some of the recent advances across the healthcare system that give you hope?
I'm a glass half full kind of person, so I'd love to take this. So I think of two key things. We've talked a lot about research and innovation, and I think the focus on moving that forward in equity and research funding and innovation has really given me a lot of hope. When I started my career, it was actually a challenge for violence research to be acknowledged as a health and equity issue, and that the idea of patients who experienced homelessness and other social advantage just didn't work hard enough. It was still prevalent, and we've really moved to seeing this as preventable and something that we need to action on and make change. And I think that's what's following with that shift in thinking is a focus in research funding and innovation. And that excites me greatly because it is so needed, and we see it every day in our emergency department. The other one that I'm really excited about is on the number of women leaders that I'm seeing. And yet there's so far to go. In Canada, the Canadian Women's Foundation has some statistics out that show I think it's about a quarter of the seats in the House of Commons are women. We know that still, I think it's under 20% of board members in the top 500 companies are women, and that there's a huge gender wage gap still across Canada. And that occurs in medicine as well. Across Ontario, approximately 30% of department heads, of clinical department heads, are women. And yet, I get to work at UHT as a female leader where there's 70% of the department heads are women. And it is an incredibly inclusive place for me to lead and feel energized, and enables me to really take some of the risks that I may not feel as confident to do. And that's why I feel so actionable in the work that I do. I feel like I'm being valued for what I do, and I'm in a space where it's inclusive. And that is so incredibly important. We know that patients need to see themselves in their healthcare workers, and our healthcare workforce right now does not represent the general population. We have so far to go on that. And yet that's still the same within leadership as well. Leaders influence policies, care pathways, research direction, and we're role models for others that may decide to get into medicine and in fact take on leadership roles where we can make change. And so for me, I have a lot of hope. I love working at St. Michael's Hospital in Unity Health Toronto for that reason in many ways, and to be in a space where we're actually way above the curve on this is really exciting. And I can tell you across North America, people point to St. Mike's and see that stat, and it's exciting to be part of that.
Maybe I'll jump in here as well, and I'll tackle this question. And also simultaneously, there's another one in the Q&A that I see that, someone's asked, are there some things that women are not doing to take better care of their health? And, I think one of the areas that I think women often and this has come up already, that we accept sometimes where we are at, and Our concerns are also dismissed and, under researched. And so we don't even realize that there's things that we can do to feel better. And one of the areas I think where this is prevalent is related to, actually, Seema said we're not just men with uteruses, but we do have uteruses. And, that is actually an area that is not talked about enough. Many women accept actually being fatigued and iron deficient. Many women accept having periods that are uncomfortable for them, not knowing that there is something more that can be done to support them. In fact, periods itself is a topic of stigma. And we've seen that stigma starting to, open up in society with, films being made about it. But one of the things that gives me hope is also researchers like Michelle Scholzberg, and who's a hematologist here in St. Mike's, and her research is really in this area. So how do we support women to better understand their periods? And so she actually has a website, Take Control of Your Period, and then how can we ensure that they're not feeling iron deficient? She wrote this great commentary with colleagues in the Lancet recently, where it talks about that actually our cutoffs for defining anemia are different for men and women. And maybe that's just because we're accepting that it's okay for women to be tired because they are having periods and bleeding. And that's not okay. And I'll say, I've suffered from both of these conditions myself and saw Michelle Scholzberg as a clinician and didn't realize how much of an impact it was having on me and and it was tremendous to get treated and feel so much better. So, it's an area that we neglect, but it's also an area that gives me hope because of the work being done at St. Mike's.
Thanks so much. I have to say that I'm totally inspired by all of the stories that you're sharing. So pleased that I can be on this panel because I have the ability to hear what's going on. We rarely have an opportunity to talk about these issues with any depth. So I feel hope from just hearing your stories. I do have one more question, and that's about trans women. So what are the unique challenges that trans women face when it comes to accessing or navigating healthcare? What barriers do they come up against? And what can healthcare providers do to create a space where they feel safe, welcome, and comfortable?
Such an important question, Pat, because this is an area for me that I've grown in and started to learn more about over the last few years. And I'd say at the core is transphobia. And that can be really overt. So it could be someone not being able to find a family doctor because they identify as trans, or not being able to access care that would help them to medically or surgically transition. But it can also be subtle, because many of our clinics, for example, we don't have good ways built into our systems to record and use preferred pronouns. And so we're often just, using wrong names, wrong pronouns. I'm going to talk about an example in a minute, but, even the way that we identify who's eligible for things often comes down to sex as determined on a health card, which is binary, male or female. I'm lucky to work at a family health team at St. Mike's where trans care is a very specific program that we focused on. We take care of hundreds of people actually who identify as trans, and we really pride ourselves on trying to provide respectful, compassionate care for that population. But at the same time, we've learned that even we can do better. So we had a patient engagement day where we asked people, about how we could improve our services. And this was a few years ago. And one of the things we learned through that was that actually people, even though we thought we were doing a good job of being respectful, that wasn't necessarily overt to patients all the time. And it wasn't necessarily overtly welcoming. So patients were like, you should be putting up rainbow posters in your waiting room. Is this bathroom gender neutral? Does every waiting room have a gender neutral bathroom? So there's just some very concrete things that as a result of this type of patient feedback we've done to try and make it more trans welcoming. We've actually also had our reception staff trained so that they understand the importance, for example, of using those preferred pronouns I mentioned. And then we've tried to take a deeper look in some of our initiatives and the way we provide care to try and reduce bias and also understand nuance that relates to the trans population. So I'm going to give you the example of cancer screening, which our group has done a lot of work on. So we've really tried to recall patients, remind them when they were overdue for their screening. And often the way this is done is by, as I said, using the gender marker on a health card. And so if your gender marker is female, we know you're eligible for a cervical cancer screening. But what if you're trans and you were born female, but you transitioned to being male, and now your gender marker is male, but you still have a cervix? Well, you would be missed when we did that kind of outreach. So we've tried to change our process so that we actually don't miss people who are trans. Specifically, we and then we did a deeper dive to even say, given this, what are the screening rates like for our trans population? And probably no surprise, we found that they were lower. And why is that? So, we did some qualitative interviews with people who were trans, who were specifically female to male trans. And we asked them, how do you feel about cervical cancer screening and what's going on here? Did you get counseled about it? And actually, we found out that most of the people who weren't getting screened had an informed discussion with their doctor, but they chose not to get screened because it was such a just gender dysphoric and upsetting experience for them to be reminded that they have a cervix, that they didn't want to do that. They'd rather get ill with cervical cancer and take that chance rather than endure that procedure. And so that was an important reminder to us that, we also have to track, for example, informed discussion as opposed to just screening rates, which is just telling us one part of the story. And what it is, it's about understanding what's important to them and providing that patient-centered care and also measuring around those specific needs.
Thank you so much. We have a long way to go, clearly. Some questions have come in from the audience, so maybe I'll start asking some of those. So before this session, we had some questions come in, and some of them are more personal. So for example, what is the biggest hurdle you have personally overcome as a woman in science? Anyone want to take that one on?
I'm happy to start off with that one. So I would say that for myself, one of the biggest hurdles was just getting taken seriously. I recall, especially earlier on in my career, being at a meeting and being like the expert in the room on a particular topic and speaking towards it, and the person chairing the meeting, the male person chairing the meetings, turned over to my male colleague and said, who had no expertise in this area, and said, "Does that sound right?" And it was angering, of course. And I think things like that, like these different microaggressions that you experience. And I think that the research definitely shows that academia is a hard place for women. But I still think that it's so important to show up. And I know that, the mentor, the women that I mentor in terms of my students who are also concerned about going into academia and experiencing these kinds of things, that it's so important to show up and to try to harness that courage to just keep doing that, because you being there, you being present in that room is a form of activism in and of itself. We need more women to just keep showing up, and eventually things are going to change. And I do believe that it actually has.
You just reminded me of something that I think, many of the women that are probably participating here, and probably some of the men as well, will recognize the boardroom environment. My anecdote is actually from a different place of work, so I want to be clear on that. But we were managing a really controversial issue, and I and a young female colleague were often the ones sort of bringing up some really critical, difficult points. And it really took actually a meeting before a meeting for us to strategize how to approach that meeting. And the other person at the meeting was the husband of a gender studies prof. And he was like the epitome of an ally, because in fact, he was the one that said, why don't we sit down before that meeting and talk about how I can support you guys? And we pulled out all of the techniques you read about, amplification, sort of like reminding people of whose job it was, not, hey, wait a second, that's what they said, the bropriation. There's all sorts of stuff out there, but I had to learn it. And I use it now very deliberately. But it was a great example of a meeting after that where we had to plan our approach, and to have an ally at that table was really, really important too. So it's a practice.
Thanks, Carol. So let's see, there are some other questions that have come in. Are there a few typical things that you see that women are not doing to take better care of their health? Anyone have any thoughts about that one?
I could take this one, if that's all right. I think that sometimes I know myself during COVID, I didn't take enough time or space for myself, to be honest. And it's happened in multiple areas of my life. And I feel like I keep making the same mistake. And I think I do it in my career and in my personal life. And I see some of the women that I mentor making the same mistake. So one example that I'll give is after I had a baby, I started having all of these really weird symptoms. You know, I was feeling fatigued and I was having a racing heart rate and my appetite was all over the place. And every time I went to seek care or talk to somebody about it, they would just sort of convince myself that like, this is how women are supposed to feel after they have a baby. They're in a different body. And when I finally came back to work and started working here at St. Mike's and I started seeing patients again, I realized that there was something different. And I had just sort of conditioned myself to realize that it was okay to feel off and that this was my new normal and that I didn't need to give that any space or time. And I ended up having Graves' disease, like rip roaring Graves' disease. And when I went on treatment, I actually slowly witnessed the return to my normal self. And I think that I just taken some time to reflect, focus on my own personal health instead of giving all my time away to family and friends and, you know, my child. I don't think that would have happened. And I think that we often will sacrifice our own comfort and our own well-being for others. There's your time is always someone else's and never just your own. And I think that, you know, the mentorship that I've gotten from other, you know, strong females is to always kind of take space for yourself, to always take time and reflect, and to make sure that you check in with sort of how you're feeling, what your needs are, whether they're personal needs, whether they're health needs, or whether they're work needs. And I think that, you know, we could definitely be doing a better job of that.
Thanks so much. So we have one that maybe many of you might want to weigh in on. And it says, really inspiring discussion. Would love to know what inspired some of you to get into science and medicine.
I'm happy to start with this one, Pat, if you'd like. It's a really good question. I certainly did not take a traditional route to get to medical school. In fact, I started my university thinking I would be an engineer, but I only lasted about, I don't know, a couple of months before I realized that that was not for me. I remember having to do an AutoCAD drawing of a parking lot, and that kind of threw me over the edge of my sanity. And I thought, you know what, I want to actually work with people. And at the time, I have to say, I had two fiercely independent, strong grandmothers who were my role models. And I don't have any family who are physicians. In fact, most of my family are teachers or, probably mostly teachers. But at the time, they were experiencing challenges in the healthcare system, and they spoke to me about their challenges. And I think that really resonated with me. And that's when I first started thinking about medicine. And I think looking back, what kind of led me to gravitate towards seniors care. And I haven't looked back since. I think there's so much we can still do to improve the healthcare experience for women as they age, really everyone as they age. And you know, one thing I'll just mention quickly is that I'm inspired about and hoping that comes out of this pandemic is that it's given our society a look and a glance at what aging shouldn't look like. And I hope everyone now is hearing and seeing, you know, all of the challenges that our seniors are experiencing and feeling motivated to help improve the care they're receiving.
Thanks. Anyone else? Inspiration?
Well, I don't know if it's inspiration because I, like Ashley, started in business, and so you know, there's a thing in the UHT, write up in the UHT about my start, and so I started in business and dropped sciences in grade 10. but what I really was missing in my career was that human interaction and fixing and those kinds of things. So it's not a surprise that I'm in emergency medicine. But when I talk about that human interaction, I think that's what's exciting about St. Mike's. And frankly, if you don't mind me talking about the Human Care Campaign, because the Human Care Campaign speaks to why we got into medicine. It's not for, the paperwork that we have to do and frankly, all the charting we have to do. It is about the human interaction, and to be in a space where we're valuing the idea that we can be part of somebody's journey through the healthcare system, which absolutely everyone is involved in, is really exciting. And to reshape that and for it to be something that's more inclusive of all people, women, men, any gender diverse, every person that lives in Canada, we can be part of reshaping that. And that's what I'm excited by. And so for me, that transition to medical school really was one of, I wanted to be in a leadership role in a space where I could make change. And I had developed such a passion for people in what I was doing. And medicine was really a great fit for that. So that's sort of my story of medicine really fit all of that. And that's why I actually identify so much with the Human Care Campaign and why I've gotten so involved in it, is because it speaks to why I'm in medicine in that journey.
Thank you, Carolyn. Okay, we've got lots of questions coming in, so I'm going to move to the next one. What advice do you give to women to better advocate for themselves in medical settings? And maybe I'll ask another one, which is very related to that, or I'll share that one. And it says, women are aware of how they may be treated unfairly by healthcare providers. When they complain, their complaints are often ignored by both male and female physicians. Systemically, there seems to still exist a culture of ignoring women's complaints and of making changes. Any suggestions on how to make these systemic changes? Big questions. Who wants to take that on?
Maybe I can start with some practical tips. The first one, which is that, how to better advocate for yourself in a medical setting. So I think it's always good to come prepared. Stating the obvious, but write down your questions and also practice and try to make succinct like your story. So what is it that's bothering you? Be clear about how it's impacting your function and your ability to work and live, and be able to tell that story to the doctor. And sometimes having notes about that is really helpful. A doctor may interrupt you as you're telling that story, but try and hold your space to say, I hope you don't mind, I just want to finish this. You can even give them your agenda or your list of questions or your story in advance if you feel nervous about saying it. You shouldn't have to do this, but it may make you feel more comfortable to have someone with you at the appointment. So if you feel nervous about it, bring an ally, whether that is a friend or a spouse, a mother or a daughter, bring someone there that you could trust who would be able to advocate for you in the moment. And then, take notes during the meeting too, so that you know what's happening afterwards. You can always ask the doctor to write something down for you, just to be clear and ensure that you understood what was happening. So those are just like some practical tips around advocating for yourself, which I'll say is only part of the issue, which I think your second question gets to.
If I could also just add to what Dr. Karen said, that it's so important to check your own internal dialogue as well when you're advocating for yourself. And what do you believe you have the right to? And you have the right to feel anything that you're feeling, irrespective of what someone is telling you should feel. It does not matter. If you're experiencing something, that is a very real experience. And I think that first part is validating that experience for yourself, because that can help you stay grounded in terms of having to sometimes continually seek out other people. I had to go through multiple specialists and doctors to get to someone who finally said, hey, I'm listening. So it takes, that perseverance as well sometimes. And unfortunately, it isn't nice to have to do that, but again, that's partially again what the Human Care campaign here is aiming to do, is so that we don't have to do those kinds of things anymore.
Thank you.
Can't also help but say, Pat, I can't also help but say, Pat, is like, try and get a good family doctor, because hopefully that family doctor will advocate for you too, you know, and so you need to have that personal connection with someone. So you shouldn't have to do what, you know, Sakina was describing. Hopefully someone else can do that for you.
All right, great suggestion. So, you know, on that issue about making systemic changes, somebody else asked, how important is female leadership in making these necessary changes to healthcare? So I'm wondering if anybody wants to weigh in on that particular question.
Oh, I'm happy to start that one off. I think female leadership is incredibly important. Having women at the table where decisions are made around resource allocation, around programs and policies, will help ensure that the voice of women are heard. And certainly as a woman in leadership, even though the majority of our healthcare workforce are women, and we are way far ahead, as Dr. Snyder mentioned, at St. Michael's Hospital and Unity Health and at Providence in terms of having women at the leadership table, we are still missing some women at this table. And we are missing Indigenous women, we are missing Black women, we're missing women of color. We need diverse women at leadership tables to help inform the policies and procedures and the resource allocations to improve the health care experience for women.
Can I make one additional add? I also think we need to work on the pipeline to train women for these experiences, because, you know, female leaders don't just come out of nowhere. And so right from medical school, even before, you know, creating opportunities for people to succeed, and having female mentorship right from the beginning of your career, because leaders, they're groomed and they're trained. And I think that's really important as well.
I completely agree with that, Seema. I have to say for myself and my leadership journey, it's really been just doors that have opened for me, but it wasn't something that I actually saw in myself, because all of the leaders I saw were men, and white men mostly. And so I've been fortunate to have some allies who have helped me incredibly along the way, and many are on this panel today too, and some really strong male leaders too who have been allies. But I think it's so important that we have women in these roles that look like who we look like, so that we can imagine ourselves in these positions, which are so important that we take. So I completely agree that we need to start right from the bottom and start encouraging women and leadership throughout their careers.
Thanks so much. We have other questions, and I'm sure that we can go on, but we are running out of time. And so I want to thank you all for joining us, and to thank you, to our Powerhouse panelists and those who helped put this panel together. I think we're going to end with the St. Michael's Foundation's president, Lily Litwin. She's going to have the final word.
Thank you, Pat, for moderating this important discussion, and to our amazing panelists for speaking to the realities all women face in their healthcare journeys. As you heard, the patient experience for women is still not what it should be. But as you also heard, our leaders are on it. Women like Pat, Carolyn, Ashley, Tara, Sakina, and Seema are just some of St. Michael's and Providence's visionary thought leaders setting out to solve a problem that afflicts healthcare institutions around the world. They reflect the ambitions and live the philosophy of our Human Care campaign. They stop at nothing to deliver the care experience that all people deserve, that all women deserve. And of course, we can't do this without our equally relentless champions, which is why I want to take a moment to tell you about our Power Circle. The Power Circle is a group of women philanthropists who believe so profoundly in the power of what women can accomplish that they've joined forces to invest in healthcare. And this isn't some kind of new idea. Women have always been powerful agents of change in healthcare. Take a look at the history of our hospitals, which were founded by the Sisters of St. Joseph, and take a look at St. Michael's and Providence today, where women are at the forefront of change, promoting health and reinventing the patient experience as care providers, scientists, and philanthropists. We're inviting all of you to consider joining our Power Circle. I did. If you're interested and if you'd like to learn more, please get in touch with us. We'd love to tell you about our plans, and we'd love to hear your stories. Write and tell us about your experiences as a patient. Thank you all for joining us this afternoon. We'll be sending a link to the broadcast so you can share with your own networks. Have a wonderful afternoon. Thank you so much.